Hi, everybody. My name is Amy Paris. I'm a OBGYN doctor at York Hospital, and I'm here to talk today about why do I leak when I sneeze. First of all, my first disclaimer is that I've been up all night delivering babies, and so if I say something incoherent, please raise your hand. Say, Amy, whatever you just said, whatever came out of your mouth, it didn't really make sense, and it's okay. I will explain better. I grew up in New Hampshire in a little town called Hooksett, which is near Manchester. I went out to California for college and medical school. I went to UCLA for med school. I came back to Boston for residency. I did my residency at the Brigham and Women's and Mass General Hospitals in Boston. And last September, I moved out here to Kittery to take a job at York Hospital as an OBGYN. And my husband and I just love it here at Kittery. We think it's a wonderful place for our family, and we've been very happy. And we, in fact, even use the gym here at the community center, although not nearly as much as we should. So that's my, in a quick nutshell, where I've been. Let's move on to the topic at hand. So the topic today, why am I losing urine? Well, there's no one single reason. There are some common reasons, and we'll discuss those. We'll discuss when it is appropriate to see your doctor, what your appointment might consist of, what testing you might be able to expect on the day of the visit, what could be the cause of the symptoms, and whether there are any risk factors that you might have for them. And then finally, and the crucial part, is what treatments might be available. So the first point, when should I see my doctor? Well, losing urine is really common with aging, right? And it's happened to all of us at one point or another. When should you see your doctor? Well, when the symptoms really become persistent. And if you find that they're disrupting your everyday life, that's really when you should think about seeing someone and seeing if there's something to be done about it. The symptoms can be a sensation of pressure, it can be a loss of urine, it can be urinary urgency. Urgency means that feeling of, oh my goodness, I gotta get to the bathroom right now or else it's gonna come out. And these symptoms can often be successfully treated after an appropriate evaluation and therapy. So what can you expect at your doctor's appointment? Your doctor will want to go over things, will want to ask you a lot of questions about your medical history, usually focusing on your past medical history and any medications that you might be taking, surgeries that you have had, any history. So we'll ask you a lot of questions about incontinence. Incontinence is a long medical word for losing urine, not in the bathroom. We'll want to know the severity, the frequency, how often it's happening, under what circumstances. We'll want to know what effects it's having on your life. And we'll want to know things that may worsen your symptoms and things that may improve your symptoms, and then whether there may be other things going on with your pelvis that are related. And we'll get into that a little more. And, this is the gynecologist, so we'll want to do a pelvic exam. Other testing that you can expect on the day of your visit. We will almost definitely collect a urine sample. Mostly we're looking for signs of infection. If there are any signs that there may be a urine infection, we may also do a urine culture. So there's a question in the back? Okay. If I speak really directly into the microphone, is that better? Because I think the guy with the volume, I don't think he's up there anymore. Is that better? All right. Sorry about that. Thank you for speaking up. So we were talking about what tests you might have, what the doctor might do to look at the urinary leaking problem. Most certainly we'll collect a urine sample and we'll be looking for infection. And then there's some additional testing that we might do, and this is a little bit more detailed. It may be a separate appointment, perhaps with a urologist, where they do some special test called urodynamics. And that is looking at specific mechanics of urination. So You might expect to have a catheter put in the bladder temporarily and some fluid put into your bladder so that we can see how much urine capacity your bladder has and whether your bladder is provoked to have muscle spasms at a particular filling capacity or whether you're leaking once we fill the bladder with a certain amount of urine. Not everyone needs that. So in addition to your exam and your testing, we will probably ask you to do some homework. This is very important for me when I'm working with patients, and that is to have you go home and do a diary. And the diary will keep close track of when you are using the bathroom and when you are losing urine. And we will try to relate that to what you had to eat or drink, what you were doing at the time when you had that loss of urine, how much volume was the loss. And this can really, you're living with this every day, but when you're coming to the doctor, you're really trying to give me a clear picture of what's going on in your life. And this is an invaluable tool because you bring it back in and we can talk about what's actually going on, the nitty-gritty of your everyday life and your symptoms. So what could be causing urinary loss? Depends on the type of urinary incontinence. So the most common kind is called stress incontinence. Again, incontinence means leaking urine. And that is the kind that happens involuntarily during a cough, a sneeze, a laugh, exercising, shoveling snow, all those kind of things. And that's related to, with age and sometimes with having babies, a relaxation in the floor of your pelvis that, just by the way your anatomy has changed makes it harder to clamp that urine in your bladder when your belly muscles are tensed, like in a cough or a laugh. So that's stress incontinence. The second most common kind is called urge or urgency incontinence. And again, incontinence, medical term, leaking urine. And urge is the sudden onset of that feeling of urgency where you feel like you need to get to the bathroom, but you can't get there on time. And this is distinguished from stress incontinence. Stress is it just happens as you laugh. Some people can anticipate that because they know it's happened before. They say, oh, I'm about to laugh, But it's distinct because it happens at the exact same time as the cough, the stress. Whereas urge, you have a feeling a minute or two or a second or two before it happens that you really need to make it to the bathroom. And for women some women just have urgency and they can make it to the bathroom. And then some women have urge incontinence, which means they have that feeling and they can't make it to the bathroom in time. And that kind of leaking is caused by spasms of the bladder muscle. And then finally, less common causes of incontinence are neurological conditions, medical conditions, drugs or medications that you might be taking. And then I put multiple reasons here because sometimes it's not one thing. Sometimes it can be a couple of different things. So before I alluded to the fact that there can be sometimes other things going on in your pelvis besides just the leaking of urine. And those other things are what's called prolapse. Prolapse just means a descending or a falling down of the pelvic organs. Basically, there are 3 types of prolapse, and I think rather than tell you about them, I'll show you pictures because I think the pictures are easier to explain. So as you can see from this picture, and I don't have a pointer, but your bladder, so this is like a cross section, like if you were to cut with a saw right down the middle, this is how a woman would look on the inside. You can see from this picture that the bladder, the uterus, and the rectum are next door neighbors. So if one droops down, she tends to pull her neighbor down with her. So we have different kinds, different classifications of what's prolapsing or falling down, but oftentimes they kind of go together, not just one thing. But a uterine prolapse, the uterus is the one in the middle. You can see on the left, this is sort of, where things are when you're 20. And then on the right, maybe a few babies later, the uterus has come down a little bit. And this shows a mild prolapse. Most women wouldn't even notice that they had this. Most women have this going on with age, and if it isn't causing them any problems in their life, most of us don't even realize we have it, then there's really no need to do anything about it. The second kind of prolapse is called a rectocele. So this is where the rectum, which is it's the backdoor neighbor of your vagina, is kind of drooping down, and it pulls the vaginal wall with it. And again, many women have this and they don't even realize it. It only becomes a problem if you're starting to have difficulty with bowel movements, or if you're noticing something protruding actually through the vagina. And then finally, this is, I think, the more common one is called the cystocele, and this is the bladder. When the bladder prolapses or droops down, and the front wall of the vagina can be pulled down. And again, if it's still up inside the vagina, many women don't even know they have this, although they might start to develop symptoms, urinary symptoms, that cause us to discover a cystocele. And this one is a little bit graphic, so that's why I prepared you. But this is what it can look like when the bladder droops down and pulls the front wall of the vagina with it, and actually can come out of the body. And this is a more serious cystocele. And again, when they get to this point is when I tend to notice that patients start to have problems with them. Usually it's discomfort, a feeling of a bulging or a pressure, something rubbing against the underwear. And sometimes it can go along with urinary symptoms like leaking urine. But again, I also have patients who have a bulge that's, protrudes actually outside of the body, and it doesn't bother them that much. And so it's not a medical emergency, but if it gets to the point here, I think it is worth going to the doctor to evaluate it to see if there's anything that we can do for you. Risk factors. So what are the setups for these kind of things? Past surgeries can be, particularly women who have had a hysterectomy, have had their uterus taken out, can be a risk factor. Pregnancy is a really big one, and childbirth, especially multiple pregnancies. And, traditionally we think of vaginal births with big babies putting you at risk. Age is a really big one, so almost everyone has some degree of prolapse and some degree of leaking urine with age. Genetics, so we have women who've never had any babies, but they have the prolapse. So some of it's just, we can't just help, it's our genes. Obesity is a risk factor, smoking, and then anything over your life that you've done a lot of straining, so a very physical job that you've done for many years with a lot of abdominal work, putting pressure on that pelvic floor can definitely set you up for prolapse, and frequent heavy lifting as well. So treatments, what can we do about these things? So this is first talking about incontinence, stress incontinence. That was the one, as you remember, leaking urine incontinence, and stress is the one where it's associated with a cough or a sneeze, an involuntary loss of urine with a cough or a sneeze. So if we find out that you have stress incontinence, but it's mild or moderate, we could talk about doing no therapy. It depends how much it's bothering you. But many women who have come to the doctor, they've come there because they want to do something about it. So the first intervention that is helpful is called the Kegel exercises, and that is like taking your pelvic floor to the gym. But the nice thing about it is you don't need a gym membership. You can do it anywhere, and nobody knows you're doing it. So if you're bored, someone is having a conversation with you and it's not interesting, you can do your Kegels. And what it is the muscles that you use to do a Kegel is, if you imagine you're urinating and you wanted to stop that stream of urine, those muscles that you would tense to try to stop the urine from coming out, those are the Kegel muscles. So you tense, you can do reps, you can increase your reps, and actually it's even for women who don't have urinary incontinence, this is a really good way to keep your pelvic floor healthy and strong and prevent problems in the future. So we recommend them for everyone. And then we can do physical therapy, and actually there are physical therapists who specialize in pelvic floor physical therapy. And it's kind of like the next step of Kegels. So this is actually kind of more like going to the gym with your pelvic floor. And these physical therapists will help you strengthen the muscles that keep everything, up inside, and help strengthen the muscles that maintain continence or keep the urine up inside your bladder. For moderate to severe stress incontinence, again, the leaking with coughing, again, physical therapy can be helpful as a first step. And then for women who don't respond as well as they would like to therapy, there is a minimally invasive surgery called a mid-urethral sling, where a mesh tape is put under the urethra, which is where the tube where the urine goes from the bladder to the outside. It supports it and basically helps you keep the urine inside your bladder. So for the other common kind of incontinence, urine leaking, urge incontinence, and remember that's the one where you're trying to make it to the bathroom and you're having bladder spasms and you can't make it on time. The two first interventions are actually behavioral. And the reason for that is because, and I had a really great urogynecologist that's a pelvic floor specialist explain this to me in residency, is that urge incontinence is basically your bladder going on strike. When you are young and you're learning to potty train, you listen to your bladder's signals. When you have to pee, you go to the bathroom. But as you become an adult and life intervenes, your bladder gives you the signal you have to go to the bathroom, and you give it the signal that you don't have time right now or there's no bathroom, or you will get to it in a few minutes after you do the other 5 things on your list, right? Am I wrong? So eventually your bladder says, okay, brain, I'm not listening to you anymore. I'm going to do my own thing. And your bladder just starts spasming. It just dissociates. Your brain and your bladder are no longer on the same page. And some of that is really at the root of this overactive bladder. And so a really effective way to rein that back in are these behavioral training where we're trying to get the brain and the bladder back on the same page. And it is a little bit intensive. You have to be motivated to do this. But the first step is just really, thinking about when you're drinking all your fluids, and are you drinking fluids thinking you're going to have to go to the bathroom in like a half an hour after you drink a large water? Is that going to be a time where you're going to easily be able to make it to the bathroom? So that's kind of just lifestyle modification. But the second one, which I really like and I think is really helpful for many people, is called bladder training. And that's basically where you put your brain and your bladder on a schedule. Okay, I'm having frequency. I have to go to the bathroom every half an hour. So you say, okay, that's what I'm going to do. We're gonna use the bathroom every half an hour, and then gradually expand that window. And what it does is your brain and your bladder getting on the same page. You're increasing your bladder capacity, and a lot of women find that their urgency gets a lot better. I don't think it goes away entirely, but it gets a lot better. And when your bladder learns that it can fill up a little bit more before it has to spasm, and that your brain is going to listen when it sends the signals, then the spasms tend to go down. And then finally, for urge incontinence, if the bladder training isn't enough, sometimes in conjunction we can do medications that address that muscle spasm and make the bladder a little bit more relaxed. And then, so in terms of treatment for prolapse, and prolapse, as you remember, was the falling down or the drooping down of the pelvic organs, we really have a long conversation, I do with my patients about, how this is affecting your life, because it's not a medical problem if it's not affecting your life. Meaning, if you don't notice the prolapse and you're not having any trouble with urination or bowel movements, it could certainly be something that we just follow over time. However, for women who really are noticing it's interfering with their life, their 2 options are called a pessary or surgery. And a pessary is, does anyone remember a diaphragm? What a diaphragm is? Kind of like a diaphragm, only it has more structure to it. So it's a plastic ring usually that goes up inside the vagina, kind of tucks everything back up in and holds it there. People look at this and they say, oh, isn't that going to be really uncomfortable? It's going to bother me. But honestly, most women, a well-sized pessary, they actually forget it's there. and it can be really, really helpful. And the nice thing about it is it can avoid surgery for women who are not excited about having surgery. Because the other option for pelvic organ prolapse is to have a pelvic floor surgery, which we do at York Hospital, and that would be very personalized toward your symptoms, where we would do a surgery to reconstruct, push the bladder or the rectum or the uterus back up inside, typically accompanied by hysterectomy, removing the uterus, and then tucking those pelvic organs back up. And that is a major surgery, but that is something that we also do, and would be happy to consult with you if you are interested. And that is the end of my presentation.